This is a 5-minute moment for racial justice educational video. This video covers how structural racism affects the diagnosis and treatment of chronic kidney disease, and it contributes to health disparities. The 5-minute moment for racial justice is a teaching framework to promote health equity and racial justice in medical education. The framework relies on a 5-step approach that discusses the clinical and learning context, the current standard of a medical diagnostic or treatment, the historical roots and bias of that standard, contributions to health disparities, and steps to take to promote health equity. This framework offers educators a structured way to talk about this topic in a concise manner across commonly encountered clinical scenarios. By the end of this video, viewers will be able to describe how race correction and estimating renal function contributes to racial disparities in kidney health outcomes.
A 65-year-old black male is hospitalized for a heart failure exacerbation. His past medical history includes diabetes, hypertension, and chronic kidney disease, managed by his primary care physician. After 3 days of treatment, he is ready to leave the hospital. The learner physician is preparing the patient's post-discharge follow-up visit and presents the plan to the supervising physician.
I thought about referring him to a nephrologist in case he needs dialysis in the future, but based off his race-corrected estimated glomerular filtration rate, or EGFR, his renal function wouldn't meet the cutoff. I think we can hold off for now.
How might structural racism be affecting patient care here? These conversations are tough to have. Let's watch how these two clinicians navigate this conversation.
This is a good opportunity for us to talk about how race is used in clinical calculators and why they may not always be valid. Has anybody ever talked to you about race correction and estimating glomerular filtration rate, the EGFR, before? This is something that was new to me as well. Let's learn about it together. It's important for us to be aware of how race correction, when we take race into account in a clinical calculation, affects the care we provide our patients and contributes to health inequities. I'd love to hear your thoughts as well. Kidney function is estimated by GFR, which is calculated from a patient's serum creatinine, a waste product filtered by the kidneys. This is one of the most common tests we order. The EGFR value has important therapeutic decisions for our patients, from how we dose antibiotics to when we refer someone to a nephrologist to whether someone may be considered for a kidney transplant. When you order an EGFR, you may notice 2 values are reported, a race-corrected value for African Americans and another non-corrected value for everyone else.
I've noticed that the values reported for African American EGFR is always higher than the non-race corrected value, and thought it meant that black people had healthier kidneys on average. Is that not the case?
That's not the case. Race correction was added after the results from the Modification of Diet in Renal Disease Study, MDRD. This was a clinical trial that examined whether a protein-restricted diet affected the progression of kidney disease. The authors also developed a more convenient formula to estimate GFR using serum creatinine, which is still the calculation we most commonly use today. The authors noticed that the black participants in the study had higher creatinine levels than white participants, and that by adjusting for black race by a factor of 1.21 times, it allowed them to better estimate GFR. The researchers attributed this finding to black individuals having higher muscle mass than white individuals. But the study never measured muscle mass itself, and to date, no scientific study has ever shown a relationship between muscle mass and race.
Wow, I had no idea. How can we explain why black patients would have had higher creatinine values than white patients then?
We know that creatinine is affected by many things: medications, diet, thyroid function, and muscle mass. Other factors such as coexisting medical diseases, socioeconomic status, access to healthcare, and education also affect kidney health outcomes. This may have explained the differences in renal function, but these factors were not accounted for in the study.
So race correction overestimates GFR in black patients?
That's right. Race-corrected EGFR is still used at many institutions, but has significant implications. Patients are referred to a nephrologist for kidney disease if their EGFR is less than 30, and may be referred for kidney transplant evaluation if their EGFR is less than 20. Using a race-corrected EGFR means you may not meet that cutoff if you're Black, and delays access to kidney care and transplants. Black patients are 3 times more likely than non-Hispanic white patients to develop renal failure, and despite making up a third of the kidney transplant list, Black patients receive only 1 out of 5 donated kidneys, and they wait 77 days longer for a donor kidney. If we eliminate race correction, 31,000 more Black patients would qualify for kidney transplant evaluation.
So what can we do instead to practice more equitably?
Many institutions have eliminated race correction for EGFR reporting. You can also order EGFR tests that are race neutral, such as the cystatin C test instead. So, what do you think we should do in this patient's case?
Well, from what we discussed, I learned that using race correction in EGFR calculation may falsely assign Black patients with better kidney function and contribute to kidney health disparities. When able, avoid using race correction to estimate renal function. Consider alternate race-neutral tests, such as the cystatin C instead.
Fabulous! Let's go see him together.
To learn more about the 5-Minute Moment for Racial Justice and other health equity resources, visit 5mmracialjustice.stanford.edu.